Yes, go ahead.
Yes, go ahead. Okay. Thank you guys for having me here. It is really a privilege to be able to speak about some of the trends that we've seen in the private healthcare space. I think something that's quite topical at the moment is funding in the private healthcare, and the reason for that is, I guess, the cost of healthcare has increased over the years, the past, call it 15 years, and how you normally get access to healthcare has actually changed. I think regulations have actually brought about quite a bit of change in the market, and I think we're going to see a lot more change coming in the years to come. Actually, the next 5 years or so. So I'm going to jump straight into it. I think just a matter of introduction. Who is Netcare? I work for a company called Netcare, and basically a division called NETCAREPLUS, and we operate one of the largest healthcare ecosystems in South Africa. And I guess it's all good and well to say that you do this. You only put to a test when there's something quite dire at stake to actually solve. And our pandemic unfortunately put us through that. We've actually treated more than 120,000 COVID-19 patients and have admitted close to 50,000 patients into our hospitals. And we had to pivot our entire business to actually cater for the COVID-19 demand in the market. It was a very daunting task, but I think the guys pulled it off, and it was actually a proud moment to be part of Netcare, albeit in a pandemic. The division that I work for is Netcare Plus, and our entire aim as Netcare Plus is to actually help more South Africans get access to private healthcare. I think traditionally speaking, private healthcare was largely associated with medical scheme membership, and I'll speak about that a bit later. But there are other ways and means to actually give people accessibility to private healthcare. Healthcare ecosystems, I think by and large across the world, have been quite complex, and complex more so in South Africa. I think South Africa is no different. And quite often, as a patient or as a client, you find yourself caught between a rock and a hard place, a funder and a healthcare provider. And a funder, namely maybe a medical scheme in South African context, healthcare provider, a Netcare, a Lancet, or doctor for that matter. And the fragmented nature of healthcare provision actually makes it quite difficult for patients to get the certainty that they want. So, practical example, you get admitted to an emergency department. The treating doctor is actually part of one practice. You go for a few diagnostic tests, and that's actually part of different practices. You get admitted to hospital, you get treated, and then quite often after that, you get bills from a whole lot of different practices. And you find yourself caught between a funder and a healthcare provider. And I think the innovation that we are yet to see in this market, and it's actually called for right now, is how you integrate the funding solutions that we have in the market with the provision of healthcare. And the ultimate aim of trying to get this right is trying to provide some certainty of cost to the end client. Obviously, you're not going to be able to provide certainty of outcome, but it's making sure that if you need care or the care that you need, you're not going to be out of pocket, or you're going to be delivered the care that you need. So I think it's something that a few companies worldwide, if you look at something like a Kaiser Permanente in the US, they've actually went far down this road to integrate how you fund healthcare with the healthcare provision. And it aligns its incentives quite well in terms of not either under-treating or over-treating, and actually making sure that people get the care that they need. I mean, just to take a step back and look at the pandemic, the pandemic has changed the face of healthcare, however we look at it. And for lots of reasons, it's actually changed the face of healthcare for good. I think there were lots of innovations that actually happened over the last 18 months or so that forced us as healthcare providers to look at the provision of healthcare quite differently. And I'm just going to highlight three main points in this regard, and talk about how we think about this and how it's going to actually affect the funding space. I think the first most important one was telehealth. Through the height of the pandemic, lots of companies developed platforms and pivoted the entire business to actually deal with the demand of telehealth. People didn't want to go into the doctor's surgery or didn't want to go into the hospital, and they actually wanted to get the care that they needed from the comfort of their home. In the US, at the height of the pandemic, 30% of all visits were actually provided by some telemedicine platform of sorts. And we've seen the same thing in South Africa. Many providers have actually developed some world-class platforms to deliver virtual care in a very different way. I think this is here to stay, and we have the basis for it in South Africa. Regulation has been relaxed a bit in the sense that now doctors can actually script without seeing a patient first, so that makes a bit of a difference. I think we get to see a lot more innovation in this regard in the years to come. I think the second part to this is actually digital health. And I guess it's a large term that's been thrown around quite often. But in essence, consumers are are expecting the exact same outcomes from a healthcare industry that they are expecting from a financial services industry as they're expecting from a retail industry. It's accessibility, price, and outcomes. And I think the rise of outpatient and home care as a result of digital technologies is going to actually garner some traction over the years to come. We have some difficulties in South Africa in terms of how home care can work, whether it's access to technology, whether it's just being able to stay at home and treat yourself. It is quite difficult, but I think this is going to change the face of how healthcare is going to be delivered in the years to come. The last one was testing and tracking, and it was quite interesting because the entire world had to pivot itself to rapidly test people in the aim of COVID-19 and track their progress over time. If you just think about how people have progressed, you can get a test through a drive-through mechanism right now. You don't have to even go into the hospital. You can get your results in the same day, whether you do an antigen test. Some of the PCR tests have actually been delivered in the same day. And thereafter, you sit at home, and if you need oxygen, you get an oxygen tank, and you use an oximeter to actually monitor your oxygen levels. And that has actually changed people's perceptions of how they can actually get testing and track their progress over time. I think the applicability of this into the chronic disease space is quite important. And if we can manage to help the population as large, I mean, South African population, at one stage, 56% of all deaths were actually as a result of non-communicable diseases. I think if we can get those numbers down, it can actually ensure more accessibility to healthcare and actually at more sustainable rates. I'm just going to put all of this on. I think affordable healthcare and regulations are, if you look at the challenges that we face as South Africa as a healthcare system, those are the two things that's actually keeping us up at night. We know that the healthcare system is based on a two-tiered system. You get general tax revenue that's actually helped you give a bit of tax credits, and then you have contributions to some product or the other that can actually give you a healthcare outcome. Unfortunately, if you look at the medical scheme market, we've gone from a situation where in year 2000, 16.5% of people belong to a medical scheme. The population has grown, and unfortunately, scheme membership has not grown. And we're sitting at a point in time now that 15% of the population belong to a medical scheme. We also have the conundrum of a shrinking insured population in the private healthcare space, and we need to see how we actually get some economies of scale and actually expose those ecosystems to a large amount of people. The last point there is about NHI, and universal healthcare is brilliant, and we support the view of a universal healthcare system. I think we're still quite far away from that, and we're going to have to work both private and public sectors, as well as through the vertical integration chain to actually see how we get NHI right or more access to healthcare for the country as a whole. Healthcare funding in South Africa is quite complex. We have three major buckets that we're actually dealing with right now. On the far left-hand side, we have, unfortunately, 45 million, close to 45 million people that are uninsured. They currently make use of state facilities, and the opportunity to give them some accessibility to private healthcare is quite big. We have on the right-hand side, far right-hand side, the medical scheme place, and we're quite familiar of that. It's actually governed by the Medical Schemes Act, and we've been sitting at that 8.9 million beneficiaries for some time. I'll speak about that right now. And in the middle is something that's been garnishing some popularity amongst the market, whether it's intermediary market, whether it's employers, whether it's actually the end client, is actually the healthcare insurance market. We're sitting at just less than 1 million beneficiaries right now. Predominantly primary care exemption products. I'll speak about that in a bit more detail, but it's actually taking lots of traction in the market, and it's growing in popularity as well. Taking a step back and looking at the medical scheme market, over the since 2015, we haven't seen much growth in the medical scheme market. It's been stagnated, and access to care is not growing. I think there's lots of factors that can be attributed to this. The first thing is we have what we have called supply side inflation as well as demand side inflation, which talks to the fact that we have an aging population with more prevalence of chronic diseases, as well as the fact that there's a bit of a supply in the market that's driving a bit of cost up. Medical scheme inflation has been anywhere between CPI plus 3% and CPI plus 4% over the years building up to COVID, and that has unfortunately decreased affordability in terms of people getting access to medical scheme membership. The latest CMS report that has been released in 2020, this is just updated to that. We've seen the number of people belonging to comprehensive plans decreasing. So from 2013 to 2020, we've seen a decrease of about 40%. And the plans that are actually growing in popularity are more your efficiency-driven options, so your network-related options that give you access to just a few facilities, hospital plans, and partial cover plans. And uh, what this actually means is the cover that people had previously as part of comprehensive plans is not there. People have less and less cover over time, and the fact that memberships is being stagnated, it means that the system is actually downgrading into lower cost plans. But that being said, we've seen the increased need for gap cover in the market. People are actually starting to use more innovative type of solutions to solve for their needs. And gap cover has come about in the market. I think it was just before 2010, where the entire demarcation debate started, and there was a court case between Guardrisk and I think it was the Council for Medical Schemes that actually allowed the existence of this product, and the Demarcation Act was enacted soon thereafter, that allowed insurance companies to cover the shortfall between what a medical scheme pays and what the healthcare provider pays. In 2012, I remember reading an article where there were just 200,000 gap cover policies. And I think right now we're sitting at a market of about 2.1 million, which means that 1 in 4 people that belong to a medical scheme actually have some gap cover of sort. We believe this market is going to actually increase in popularity in the years to come, as you see more people downgrading and actually opting for lower cover plans. And the fact that if you look at out-of-pocket expenditure from 2013 going from 19 billion to 32.8 billion in 2020, it shows that people are actually looking for some cover. And what they're actually looking for is certainty. Certainty that if I need the care to get me back up on my feet, it will be covered. And the introduction of these products are actually giving you that. I think the knock-on effects is there's one of two things that could happen in the years to come. The first thing is we might see more downgrades as a result of the existence of these products. But I think you can also see the situation where people that do not belong to a medical scheme now being able to afford something and buying a gap cover product to give them the level of cover they actually want. Primary care exemption products, from an insurance perspective, currently there are about 10 licenses that have been issued by the Council for Medical Schemes. These policies have grown in popularity over the years. We're sitting at, I think it's just over 500,000 beneficiaries belonging to a primary care exemption product. And it's delivering everything from doctor's visits to optometry to dentistry and a bit of pathology and radiology. And employers are looking to actually fund these type of products. You're looking at a premium about anywhere between 250 and 350. And they're looking to give their employees some sort of cover in terms of healthcare. So in the last few years, and we also see that going into the future, more and more employers are going to look at some sort of low-cost benefit option to give their employees some sort of cover. The one product that has been growing in the insurance space over the last while is what we call accident and trauma. So basically cover for your medical care as a result of an emergency that you've encountered. And the need for that is quite simple for us. If we look at, this is just using the Netcare data that we've analyzed, the medical costs above 250,000 rand per event were more than just over 45% of the total cost of what we've seen in the market. And what also talks to that point is if you look at the top 20 trauma events in Netcare in 2019, we obviously didn't look at 2020 because that was a very different period. But if you look at 2019, the top 20 trauma events actually cost more than 2 million. And the reason why this is quite important is being able to get access to the care that you need and being able to get back up on your feet determines on whether you can still support your family and give them the livelihoods that they need. It's not about just getting the care. It's about being able to live the life that you were living before the event actually happened. So we've seen these type of products actually growing in the market. Quite a few players are playing in the standalone market in accident and trauma, and it is actually a need that's worth solving for as well. In essence, what we have is we have multiple products from a funding perspective used to access healthcare. Everything from medical schemes products to the Insurance Act, demarcation, banking. And we find that the environment is in flux. It's largely driven by regulatory changes. We expect more regulation changes in the years to come. The CMS have already issued, it was Circular 80 and 82 2 years ago, where they did state that they're going to bring a low-cost benefit option framework out in the market. And we look forward to that because it can actually provide more cover into people that actually need it. We see insurance offerings growing into popularity, so lots of new players entering this market trying to solve for a need worth solving for. And there are two parts that's actually giving us hope at the moment. I think the first part is there are lots of healthcare innovations, and whether it was due to the pandemic or whether it's due to just a matter of technology catching up with us, it's going to drive new offerings into the market, whether it's at home care or whether it's stuff like telemedicine or testing and tracking. We believe that that's going to ensure accessibility in the market. The biggest part is affordability at the end of the day. What can people afford? And solving for that barrier is going to be quite key for the players into the market. The need for an integrated ecosystem, and it's just our view right now that we hold, the need for integrated ecosystems is actually quite key. Integrating funding with the provision of healthcare to give clients the certainty that they deserve is going to be key to actually moving this market forward and giving or ensuring accessibility for a lot more people. And innovation in the healthcare ecosystem is going to happen as a result of vertical partnerships that's going to exist, as well as the partnerships between public and private sector. We need to actually break down those barriers and make sure that we can ensure adequate healthcare access for everybody. That's me, and happy to take any questions. And thank you for having me here. It really, really is a pleasure. I hope I added value to your lives.
Thanks a lot, Teshlin. Very, very insightful piece. There are one or two questions that are coming through from the chat, but maybe before we get to that, one of the things is, how do you look at addressing healthcare to the masses by means of digital health? When we look at the demographic and we look at the current lay of the land in South Africa, there's very few individuals that would potentially have the access to the digital mediums that are sort of mainstream to most consumers or to higher LSM consumers. How do you look to bring a sort of varying stage of maturity around these digital offerings to reach greater numbers of individuals and individuals in remote areas? What are your thoughts on that?
Look, it's a brilliant question. I guess, and the reason why it's a brilliant question, there's two barriers that actually exist in the South African market currently. Smartphone penetration is one of them, because if you look at digital access, you're looking at some sort of smartphone that you actually need. The second point is data, or access to data. Data is quite costly in South Africa currently, and if we look into that market, being able to consume data is difficult. So we're going to have to see how we break down those barriers before we solve for the healthcare. I think having zero-rated type of solutions where you don't have to pay for data is going to help. Being able to be flexible of you don't have to have a video call. You can have a telephone call and still having the right doctors that can actually still diagnose or treat those patients over a telephone call is quite key. One of our key lessons is it takes a certain amount of skill to actually diagnose a patient over the phone. It's not the same as seeing somebody face to face. And being able to make those doctors available to those patients is quite key. It's one of our key lessons over the last while. And price point is always a barrier as well, being able to, you can't just take a virtual consult and price it as the same thing as the face-to-face. You're going to have to look at price point and being able to make flexibility. We have a long way to go. In all honesty, we have a long way to go. But the need is there, the will is there from lots of companies, and I think we're going to break a few barriers in the years to come.
So maybe just two questions coming through from the participants. The first one, do you have any indication as to the adoption rate of telemedicine in South Africa during the pandemic? And is that kind of comparable to the 30% that has been seen in the US?
So we've had some data coming through. Obviously, from a NETCARE perspective, Medicross is part of our stable, and we've seen telemedicine grow through the height of the pandemic. Telemedicine is an interesting ecosystem to solve, because it's not just about the patient's willingness to engage in a teleconsult. It's also about how the doctor marries those two and being able to get those two together. And obviously, there's a medication part that comes in it, how you script and how you get your medication. We've seen an increase over the peak of the pandemic, but I think as the pandemic or as the peaks went down, people went back to the normal face-to-face consults. I still think that there's opportunity for us to get that right. We've also seen certain market segments use it more than others as a matter of, or out of convenience more than anything. So your first question is probably the most important question, Trendon. How do we solve for accessibility of telemedicine into a market that traditionally did not have access to doctor consults? And we're not there yet, eh? We're not there.
We're not there. No, fully agree, fully agree. And then maybe the last question is that what's your views on the public and private healthcare convergence in the light of NHI?
There's two parts to this, right? The one part to it is a funding component. I mean, people quite often speak about the 450 billion that we have, and that's enough to solve for healthcare, and the fact that half of it is used by 15% of the population in terms of what you have in the private sector. I think the convergence is quite important for us to solve it. And when I say convergence, it's actually a partnership more than anything. How do we actually partner to deliver quality healthcare for more people? And I think we can do it in a sustainable way that can actually take South Africa forward as a whole. We're quite far from that, and I think some of the conversations have been had, but we need to fast track this conversation if we want to get NHI up and running.
No, thank you very much, Teshlin, and I appreciate your time this morning.
Sure. Thank you for having me, and enjoy your day. I'll see you guys on the panel.